Hello again, everyone. Just a short announcement before I introduce the next speaker. If you notice on the message box to your right, there's a pinned message on the feedback link for yesterday's and today's conference. So, at your own free time, if you can fill up that feedback form, we will greatly appreciate it because that will help us in terms of what we can learn from running the course and how we can make it better for everyone in the future. So, this session on spiritual care will not be complete without a talk from a chaplain. Coming up, we will hear from Chaplain Sakinah Al-Habshi. She specializes in spirituality in community, healthcare, and disaster or humanitarian field. She has a master's in Islamic studies and interreligious chaplaincy from the Graduate Theological Union, Berkeley, California. She also completed a clinical pastoral education, spiritual care residency, and fellowship at Stanford Hospital, California from 2019 to 2021. She also trained in classical Islamic sciences in Malaysia, Indonesia, and Yemen. She will be discussing about from the womb to the tomb, the role of a chaplain. Please welcome Sakinah.
Hello, good morning. Assalamu alaikum. Peace be up. I'm echoing. Okay, got it. Assalamu alaikum wa rahmatullah. Peace be upon you all, and a very good morning in Malaysia. I'm currently in the US, so it's evening time for me here. Yes, we have the slides in slideshow mode. Perfect. Thank you so much to the organizers, to Jinsu and to Saiful. Okay, are we able to go to slideshow mode so it can be a bit bigger? Okay,
I think,
that's okay.
I think
That's just
yeah.
okay. So my topic is a little bit more of giving you a peek into the practical working end of what goes on in a chaplain's day-to-day schedule. So you've heard from like Dr. Christina Puchalski and some of the other speakers as well on a bit more on the theory, and they shared some cases of the application of spiritual care and spiritual support. And I will go into yes, sorry, just getting some messages from the organizers. Okay, and I'll go into sort of taking you into a day of what happens in my role as a healthcare chaplain, and I will explain it with kind of taking it more of a hospital context, but it would be similar in a hospice environment. I know many of you are from the hospice um, hospice sections as well. So what would be different would be then physically going to the patient's house and things like that. And a lot of the things that happened would happen sort of like less intense than it would in a hospital environment. But in general, the principles are applicable to both. Yeah, I still don't see my slides. I'm not sure if you all see my slides. It's okay if it's small, just share whatever is there is fine. So, what we will not cover, I just want to share, we will not be covering the theories and explanations of what is spirituality, what is spiritual care. You've had a lot of that already in different sessions in past years. You had some of that with Dr. Puchalski. We will not be covering things like specialized spiritual care. Like there was already a session on pediatrics, and there are other specialties in spiritual care as well. So we will not be covering things like that. It's just more of a walkabout and how you might see that a chaplain might function in this interdisciplinary team. Um, and while some of these things, these are not all going to happen in one day. What I have listed on the day in the life of a chaplain, it may not happen all in one day, but over the span of like a week or a few weeks, a chaplain in general would cover a lot of these activities. So, and it also depends on the size of the hospital and the capacity of the hospital. I was in a way I feel blessed to have my training at Stanford. So Stanford's a level one trauma hospital, and the chaplaincy team is also larger than many other hospitals and more diverse. and they were very integrated with the healthcare team as well. So we did have some liberties that might not be available in some smaller hospitals, where the chaplain plays a role that is more familiar dekat Malaysia, kan, where you might call in the priest or the ustad or the sami, and they just come in and pray and they leave, and they're not really integrated with the healthcare team. So I think that's the difference here, and that's what we're looking forward to encouraging and promoting back home. And I'm a big supporter of that, and hope to collaborate with you all as well. So next slide, please. So we'll talk a bit about charting and disciplinary rounds, and then when we're involved in Code Blue, death and dying, other crisis, how we provide support to the staff as well, not just the patients, but also the staff, how we're involved in advanced directives on call, and also education and training. Some of the chaplains here do a lot of training with the clinician teams. Both ways, we receive training from them, and we also provide training on communication and things like that. And with hospice chaplains, there might be home visits and funeral bereavement and some additional support that extends over a longer period. Okay, next slide, please. Next is sources of referrals. So one question that I get frequently from people is, how do chaplains see patients? Like, how does it work in the US or in places that have like chaplain integrated into the team? So how we end up seeing patients come in a variety of ways. One is that I see patients that are I'm assigned to a specific unit. So I was assigned to oncology, to cardiac, to the cardiology unit, to the ICU, to bone marrow transplant, to neurosurgery. So I have a few units that are under me, and I do a triage based on chart review. So I come in the morning, I look at the charts of the patients in the different units, and I might notice what critical changes or emergent needs. Somebody maybe just arrived, somebody maybe just came out of a difficult surgery, somebody maybe just transferred in for a lung transplant or a heart transplant, so like a bit more serious cases. And so I triage from there who I might have time to visit, because I may not get the chance to actually round with everybody. Another source of referral is through clinicians, and that can happen automatically through Epic, our charting system. So a clinician might put in the system that I want to refer this patient to a chaplain, or it could be through word of mouth, or they inform the nurses in the unit, and then the nurses inform the chaplains when we come and assign to the units. It could also be through interdisciplinary rounds and meetings. So when I join the rounds in the morning, and we have discussions there, and we get referrals from there. I'll talk about it a bit more later. Patient requests, family requests, and then of course when we're on call on weekends or at nights, you get the automatic on-call pages. And some requests are automated in the system, and some, for example, when a death happens or a code blue happens, that's usually automated in the system, and we'll get a notification, get a call as well. Okay, next is, I'm sure everybody's favorite part of the medical system is charting on the various softwares that we have. So we used Epic in our hospital. And so one part of Epic is I get to review the patient's information on it before, and then I chart also. As a chaplain, we put in chart notes, and as I think Dr. Christina Prochalski talked about this as well, we read chart notes, we put in chart notes, and in some hospitals, there is a bit more information in Epic that's tailored for spiritual screening and spiritual assessment. So I don't know if you can see the screenshots, but for example, some hospitals might specify this a space where you can enter spiritual needs in a chart form, and then you can also type additional comments and things like that, and that can be integrated into the system. Next, please. Second, yeah, and in the aspect of interdisciplinary roles, I think that's probably one of my favorite parts of this role, this work, that we get to be really part of the clinical team. And that's not always easy. I know it sounds nice on paper, but we'll talk about the barriers later. Not all clinicians are very aware of or welcoming necessarily, because of misunderstanding and myths and misconceptions about what chaplains do, and they may not always be very welcoming of having a chaplain on the team. And then there are others who are very interested in holistic care and value the importance of emotional spiritual support. and maybe they've experienced how having a good chaplain on your team can really benefit the patients and the staff, and really be like a more robust system. So the roles include being involved in daily and weekly rounds meetings, patients, family meetings as well. In some places, I have heard, I can't remember where, I think it's in like UCSF, San Francisco University Hospital, their palliative care team. If I'm not mistaken, the chaplains are the ones who actually chair the family meetings, some of the family meetings or most of the family meetings. And that's the role that the chaplain, to that level in some places. That's not the case in most hospitals, but we're usually part of family meetings, especially when there's important discussions happening, or change in treatment or change in diagnosis. We also sometimes do joint visits. I really enjoyed at times collaborating with like the respiratory therapist or the physical therapist, occupational therapist, because they're working with the patient physically. And sometimes that's also when the patients are feeling very frustrated about something, and just it just worked for us sometimes to have like these co-visits that then I stay back and stay with them, and after the PT leaves, and then reflect on the visit and how it might have been very frustrating for them to do certain activities today, and how it might have impacted them emotionally, spiritually, giving up hope and things like that. Ethics consultation, if there's a complicated case, we have ethics, uh, what is it called, yeah, ethicists who are involved and part of the medical team, and chaplains are sometimes consulted, especially if there's issues related to religion and spirituality. For example, there was a case where we had a car accident, and the lady was pregnant and carrying, I think the fetus at the time was like 22 weeks or something, and I think like viable fetus was about 28 weeks. So there was a discussion of, do we keep her body running for another 4 weeks and then try to deliver this fetus? And so it became, a very big, more spiritual, religious discussion as well on decision making and involved ethics teams. I put in a resource over there that's taking your place at the table, which is involving chaplains in family meetings and interdisciplinary care meetings. And from some of you, I believe, are in the spiritual care field, maybe not all, but I think that was a useful article to kind of encourage chaplains to step up. And then sometimes in certain teams, you are the one that has to invite yourself to those meetings and prove yourself credible and worthy, and how you're really part of the team, and just kind of claim that space at the table and be part of the team really, inside out. So that's something I always encourage. Okay, next. Thank you. I think I'll skip this because Dr. Buchowski talked about it already, the difference about screening and history taking, and how generalists, like a lot of you healthcare clinicians who are trained in some level of spiritual screening, history taking, may be able to provide. And then also more the deeper spiritual assessment, which takes a bit more time. And it's not just about answering a checklist of questions, it's about that embodied presence. It's about interpreting the stories, like what was shared by the speaker earlier, Dr. Shamini, I think, interpreting the stories, interpreting underlying values and emotions that come out. So it's a bit more multidimensional, and it requires training, of course. And I included some general spiritual questions that might be helpful for screening purposes initially at the bottom. I think the resources will be there. Okay, let's go next. I know, yeah, next slide. Thank you. I also understand that clinicians don't always have the time and the opportunity, and it's not really, in a way, your role to be doing the deeper spiritual assessment. And sometimes you might want to, just out of your own personal desire or interest, or your own personal appreciation of how much emotional and spiritual support um, impacts your patient's health, can. So whether you want to do it, tapi sometimes you can't, even just your time and the amount of people you have to see, nurses, physicians, and all that. So I was appreciating these two comics a little bit, reminding me from the patient's perspective also, and how humor is kind of a big part of spiritual care and emotional care at times in the middle of all the stress. Yeah, let's move on to the slide. We get to a little bit of the main part of the work, which is the actual being with the patients. Where did that thing go? Okay, with being with the patients and the spiritual assessment work itself, interventions, and as we mentioned earlier by the other speakers, this is the time that patients are coming up or their family members are coming up with these difficult questions, and often it's not anything that we really can answer, but we accompany the processing. So I put that I feel the role of chaplains comes down to three main spiritual care provider comes into three main roles. The one first is to support, and I think that's probably the most common and easily understood role. Oh, we provide support. Oh, we provide compassionate care and empathy and presence. The other is the role of clarity, guiding decision making, and that requires, I feel, like a overlapping skill set. You're providing support, but then you're also now guiding people in making very difficult decisions on when they might change treatment or when they might terminate certain treatments for their loved ones or for themselves. Decisions like whether they might want to terminate a pregnancy due to whatever's going on. Decisions like, do they quit their job if they're not able to be able to function in a certain level that they used to because of their illness? So decisions on whether they leave their faith, whether they just give up faith. I mean, that's sort of like a decision making point as well that people go through. Um, so I think that's the other perspective of our role, is to help guide people through decision making processes that help them be clear about what their values are, their religious, their spiritual values, their emotional values. And then the third role is to challenge. And I don't say that in the sense that we just like try to fight people and challenge them. It's not what I mean. But sometimes there's certain unhealthy mindsets or reframing that might need to happen. And chaplains are, of course, very trained to not bypass the process. So it's never about spiritually bypassing, like, oh, you should just accept God is testing you like this, and therefore you should be patient. Anyway, you'll meet your child in heaven, blah, blah, blah. It's about maybe asking certain sharp, challenging questions that help them to themselves to reflect and reframe uh, their values and reframe their understanding or their perspective of God. Maybe if they feel like God is a punishing God and this is why this is happening to my child and I've done bad things in my life and therefore now I need to pay for it. If that works for them and that then they feel they're comfortable in that, it is not our place to try and change that and be like, no, you shouldn't think that way. No. But we may challenge and we may invite them to reflect deeper. Is this what they really feel? Or is this belief? Is this something that they feel was imposed on them maybe by a certain upbringing or certain misunderstanding of and perceptions of their own teachings, their own faith, their own emotional experiences? So that role of challenging, the supporting role, the clarity role, the challenging role, and I would add advocate. And I think Dr. Pochalski also talked about that. I forgot to include advocacy, where you might be advocating for certain religious and spiritual rights of a patient, to be respected by the medical team or to be clarified. So you may advocate certain things to the medical team who might not understand certain perspectives or why something might be so important to a person. But for them, there's a deeper underlying purpose of it. It's not just about, oh, I don't want to take this treatment because of XYZ. And then some details on part of that involves assessing the positive and negative religious coping mechanisms. And also sometimes you get to visit once more. Yeah, you guys know this. Yeah, and at times as a chaplain, you might coordinate referrals. So I have many times referred patients to psychiatry for additional mental health support if I believe that this is they need that additional specialized care. So referring patients to psychiatry, referring patients to specific or bringing in specific religious leaders for specific rituals that I'm not able to do myself for a certain need. So I am still their chaplain, but I'm collaborating and connecting them to maybe a different religious leader that can provide a specific ritual that I might not be able to facilitate for them. Yes, and then some of the common spiritual care assessment models at the bottom of the screen. Okay, next. Thank you. I think we can skip this part. So this just has two main models: the Fitchett 7x7 spiritual assessment and the spiritual A model that a lot of chaplains use. And of course, it's not quite a black and white thing. We usually tend to integrate various models, but you can research this if you're interested. And next, please. Another role that we're often involved in is the advanced care planning conversations. This could be while a patient is filling in the form and explaining the form to them. This could be discussing the forms with the family members as well. So so chaplains would have also training on the ACP, and I know we have many models out there. I've used different models of ACPs, and I've seen a lot of them are actually quite straightforward and short. I like the Stanford form, and you can find it online because it also has pages that describe a little bit more detail about what are some of those treatments, the life sustaining treatments, and also the ability for patients to understand that there could be more nuance to that decision making. It's not just about, yes, do I want to have artificial nutrition or no, but it could be about how long or in what capacity, or what does what is the impact of having something, saying yes to something for 1 week versus saying yes to something, a specific treatment for 3 months has different repercussions. So the form has a little bit more space for nuance that helps patients to have those conversations. And again, it's not so much about the form, but it's about those conversations, right? Like at the end of the day, if the family members are on board and the clinicians are on board and everybody knows what this patient wants and needs, it doesn't have to be on that piece of paper, but it helps to have it on the piece of paper because it initiates those difficult conversations. And often those conversations don't happen until there's a piece of paper, and then everyone's, oh, okay, we have to like understand what this is. I won't say more about this, but I will put in a plug. Next weekend, we have the Kaseh Hospice Interfaith Dialogue, and we are specifically that whole event will be discussing advanced care planning, and different spiritual and religious perspectives to advanced care planning. So come and join that next weekend if you are available. Next slide, please. We are wrapping up on my time, 20 minutes. Since the topic given to me was womb to tomb, so of course we need to include the circle of life, and one cannot exist without the other. And chaplains are also involved in the beginning of life, in celebrating life. So it's not all just like the doom and gloom and difficult. Well, it's all difficult, really, but we're also involved in celebration of joy and of love and of life, and hopes and dreams. And sometimes it's mirrored when there is a birth and they want like a chaplain present as well to maybe do a prayer for the baby and the family. And on the other hand, it's sort of like a similar experience when somebody is leaving this world, right? The dreams and hopes that you have for a newborn child, and then sort of on the flip side, when you're passing away, you're reflecting and reviewing your life review and your legacy of the dreams and hopes of a life that has been lived, and how you can surface that with a family and invite them to share about maybe their grandmother or their mother or their spouse who's dying, and how they can share stories about somebody who is passing. And sometimes it's really beautiful when I have a large family gathered and I invite them to macam, yalah cerita lah, like nenek dulu macam mana, like what was your favorite time with her. So this cucu, this grandchild cerita something else, and then that other person cerita something else, and then they don't even know, like, hey, you did that with grandma, like I didn't know grandma used to do that. So they're also learning about this loved one who is now dying, and through each other's stories and through our facilitation of that. And then there's the paperwork, of course. And then we also have the No One Dies Alone program that chaplains help to coordinate with volunteers. So if some reason family is not able to be around and the patient is dying, and we do try to get our volunteers to come in and be with them towards the end of their life, so that they are not alone, if that is something that they want and the family wants, of course. All right, last slide. Almost last. Staff support is another big part of what we do. I talked about education. Sometimes we do trainings or combined trainings on communication, on moral distress, moral dilemma, how health care clinicians themselves can take care of their own needs and their own struggle in navigating the difficult work. And sometimes we do this like periodically. There, like for example, that was like the meeting room that I set up. We dimmed the lights. We just had like the screen filled with nature images coming on the TV screen, had hand cream lotions, and nurses and clinicians can just pop in and out and spend a few minutes before they go back out to their unit. And we try to have some of those things happen periodically, like at least once a month at least. It would be ideal if it could be more. Sometimes we also join when during shift handover, especially if there's been like a difficult week or many deaths or something difficult's happening. We try to be present when they are doing a shift handover, and we do like a breathing exercise or just check in with people. And then we also have ongoing touch point. I had like a board in the nurse break room where they have lunch, spiritual care corner in the board, and I would always use humor. To me, that was one of the what I felt was beneficial and was useful, was using humor to remind them of self care, to remind them of like just emotions, challenging deep emotions. I'll share some examples as we end. Next slide, please. Barriers and challenges. Professional training to be a certified chaplain is rigorous and long. If we have to have master's degrees, we have to have clinical pastoral education training in hospitals, and getting certified includes 2,000-3,000 hours of training and thousand lots of writing. So the training and education is long, and so it's also quite challenging to get people in the process. And it's a field that's still growing, and not many people are aware of the level of rigorous training involved. Another barrier, I think, is the misconceptions and resistance sometimes from patients, from families, from healthcare staff. So events like this are so helpful to just talk about these things more and educate each other and share and benefit from each other, and to just kill some of those misconceptions that unfortunately impact the care that we're able to provide our patients and each other. Limited chaplain availability. So there is a growing demand, I think, everywhere, really, not just in the US, but then the availability of the inconsistency and the availability of the level of training and quality of chaplains, especially in interfaith training. I think it's really important that chaplains, especially if they're going to serve in an interfaith environment, to have that foundation and training of being an interfaith chaplain, and to underscore the professional ethics of do no harm. In general, the healthcare environment, this is easier. Being a chaplain, like in a prison or university or other disaster relief, the criteria is less strict as a healthcare chaplain. So, in general, I think the level of quality chaplains that you get in the healthcare field, they tend to have to go through a lot more like CPE training, the clinical pastoral education training, and exposure in a clinical environment. And I think another barrier and challenge that we all share in this field, palliative care, hospice, and then spiritual care across the board, is measurement. Often at the end of the day, they still want to know, like, how do patients benefit? How can I measure that patients benefited from chaplain visit? Why can't you do this in 10 minutes? Why do you need 30 minutes? How do you get all those stories that Shamini got from that little girl? How do you do that in 10 minutes? You can't do that in 10 minutes. And then you can't start limiting. So this tension of trying to increase the benefit to expand to more patients, but then also with the limited number of chaplains that we have, and then a desire to measure outcome financially, measure outcome by productivity, is a tension. And I know that Dr. Christina Pochalski is working a lot in this intersection, in research, in measuring outcome and productivity and things like that. And I support that. And also, I believe this is a field that it's you can't remove the human out of it. You can't remove the magic out of it. Like, that's part of it in a way. Okay, thank you very much. Then last slide. And I wanted to share one of the comics that I often share with my healthcare folks. It's called The Heart and Brain. It's an Awkward Yeti, and they do a lot of kind of healthcare related emotional, spiritual support. So that's Heart and Brain. And thank you for listening. Thank you for your support, and appreciate your time, and look forward to the Q&A session. And hopefully a visit to Malaysia soon and we get to meet in person. Assalamualaikum warahmatullahi wabarakatuh. Thank you.
Walaikum salam. I was just about to say, Sakinah, that we can't wait to have you back here at some point because it's been a while, I think.
Oh, visa issues, and then, well, good news is that I did get married the in a way, unfortunately, that is here, so I will not
Yeah.
be moving back to Malaysia,
No.
but I will still my home, and my mom is there, and I'm definitely coming back.
Yeah. Okay. So thank you very much. That's a very enlightening talk. Yeah, I think it does evoke some questions from the floor. We'll end this session for now, but then we'll come back with the other speakers for the Q&A. Yeah.
How do I see where the questions went?